Kia ora, I'm Alex Popovich and I'm a breast surgeon and menopause specialist here in New Zealand. Today, I want to share a story about HER2 positive breast cancer. This is a subtype of breast cancer where we have seen the most dramatic improvement in outcomes over the past 3 to 4 decades. If you've been someone who has been diagnosed with HER2 positive breast cancer or know someone who has been, stay with me as I explain what HER2 positive cancer means, how we've transformed the prognosis of this once quite a deadly cancer, what a modern treatment journey looks like for a patient with HER2 positive. The progress we've made is truly inspiring. So let's dive in. Every cell in our body has receptors, and these are like little antennas that are sticking up from the sides of it, as you can see on the picture. When we talk about HER2 receptor, what they do is they send signals for the cells to divide and grow. As you can see on this picture, normal cells has only few HER2 receptors. To the right is abnormal or HER2 positive breast cancer cell. And this cell has a lot more of these receptors. And so what that means for the cell is if the signal sits on this receptor, it will send more signal for it to divide. So too many HER2 receptors send more signals, and these cells kind of grow and divide widely, and you get more likely cancer cells because the cells are dividing more often and growing more quickly, and eventually the cancer cells start growing out of control and invading into surrounding tissues. In New Zealand, around 15 to 16% of all breast cancers are HER2 positive breast cancers. When we look globally throughout the world, the number is around 15 to 24%. So why was HER2 positive cancer so scary? So if we go back in time, in the late 80s or 90s, if you had HER2 positive breast cancer, what it meant was that this cancer grew faster than the more standard ER/PR positive HER2 negative breast cancer. As the cancer was growing more quickly than the regular breast cancer, it was more likely to spread. And recurrence was also more common after the treatment, and the standard chemotherapy and hormone therapy for ER positive cancer didn't work as well. So women had worse prognosis. In the 90s, the prognosis was that if you had a stage 1 HER2 positive breast cancer, you had probably 97% survival. If you had a stage 2, it would drop down to 88%. And then if you have a stage 3 breast cancer, then your survival rates was significantly lower. It was only 28%, 5-year survival. In the late 90s, scientists made a new medicine called Trastuzumab or Herceptin. What it does, it basically clicks onto the receptor and then it doesn't send the downstream signals, stop cells from growing quickly. And so what it did, it significantly improved the survival of HER2 positive breast cancer. So if we look now of the survival, stage 1 survival is 97%, stage 2 survival is 90%, and stage 3 is 78%. If we look at the difference between in 90s or late 80s survival for the breast cancer treatment, if you had a stage 3 disease versus now, was almost 3 times as low. So we've improved the HER2 survival 3 times by inventing all these HER2 positive drugs. Herceptin is not anymore the only drug. As you can see on this diagram, you have monoclonal antibodies, that's Trastuzumab or Pertuzumab. The other drugs are tyrosine kinase inhibitors, and they block the receptor on the inside of the cells They are lapatinib, ratinib, and tucatinib. They always have such a hard names to pronounce, don't they? And then the newest drugs are these drugs called antibody drug conjugates, where you have monoclonal antibody like Trastuzumab, which carries chemo straight into those cancer cells. And they're called antibody and drug conjugates, or TDM1s. So Kadcyla is the most common of these medications. Neoadjuvant therapy is treatment before the surgery. Most often it's chemotherapy. If we call it adjuvant chemotherapy, then it's after the surgery. For many HER2 breast cancers, we will use chemotherapy first before we do operation. So how do we decide that? If you've had lymph nodes that are involved with cancer, that the cancer has already spread into them, you will get neoadjuvant chemotherapy. If the cancer is over 2 centimeters, you will get neoadjuvant chemotherapy. If it's between 1 and 2 centimeters and no lymph node involvement, then it's a discussion. All this may change depending on the patient's medical problems that they might have, whether or not the chemotherapy is more likely to cause more problems than benefits. That's a discussion that each patient will have with a medical oncologist. Why do we do this? So there are several reasons why we do this. So number one is if you have a big tumor and the breast conserving surgery is not possible, then by shrinking the cancer, it may allow for breast conserving surgery. But more importantly, we can assess how their cancer is responding to the chemotherapy. So if it disappears, which happens in 50% of these HER2 patients, these patients have much, much better long-term prognosis than for those who the cancer is still there. And for those who the cancer is still there, then these days there is a more chemotherapy that's added after the surgery in that case. That does further boost the survival in that group of the patients. What does the modern treatment journey looks like? Number one, we make the diagnosis of HER2 positive cancer. You send the core biopsy from the breast tissue and our lymph nodes and confirm that the patient has a breast cancer, and they get tested for ER, PR, and HER2 markers. And that will tell us whether the cancer is ER positive, PR positive, or HER2 positive or negative. Once you have a HER2 positive cancer, according to the lymph node status and the size of the cancer, we make the treatment plan. So if you have lymph nodes that the cancer has already spread into, then we want your treatment journey to start with chemotherapy first. If you have lymph nodes negative cancer, then it depends what size the cancer is. If the cancer is over 2 centimeters, you will also these days recommend chemotherapy first. If you have cancer that's between 1 and 2 centimeters, as said, lymph node negative, then we need to discuss, and it's case by case scenario, whether or not to start with chemotherapy first. And I think these days, the hardest thing is to figure out, are we over treating people with a chemo or treating them? If you do have chemotherapy, there are different regimens of how long it goes for. And what I'm talking about is more standard type of chemotherapy rather than Herceptin. Herceptin goes on for a whole year. Once that standard chemotherapy is finished, then after a break while patient is recovering from the chemo, we operate, and normally we try and do it somewhere between 3 and 6 weeks following stopping the chemotherapy. And the Herceptin continues during that time. Now, some people who have smaller cancer might go for a surgery first and then have a chemotherapy once we know exactly the size of the tumor, whether or not lymph nodes are involved. If you've had a neoadjuvant chemotherapy, if the cancer is completely gone, great. You will continue to finish your Herceptin. If your cancer hasn't responded or gone away completely, then they start adding other HER2 targeted therapies on top of that. So whatever your journey was, we always keep an eye on you. Different places do different things. The standard is 5 years follow-up with the breast surgeon, and then also radiation oncologist if that patient has had radiation. The treatment is highly personalized, and everyone's plan may look slightly different. Over the last 30 years, we have significantly improved the survival of the HER2 positive breast cancer, especially for stage 3 breast cancer. In 80s, overall 5-year survival was around 68%. Now it's over 90%. What will happen with HER2 patients in future? The scientists are working on even better medications that have less side effects. The next challenge is personalizing further the treatment plans. Who needs less treatment and who needs more treatment? The less treatment you have, the less side effects you have, but we need to balance improving survival. HER2 positive breast cancer has become a great example of how good science saves life and how good science is trying to minimize the impact of treatment on breast cancer patients. And remember, HER2 cancer used to be a very scary diagnosis. And in some ways, it still is. But now we have amazing drugs that have significantly improved survival for our patients who have HER2 positive disease. Thank you for watching this video. If this video has helped you or you like this video, please like, comment, subscribe, and share with someone who needs this hope and information today. If you have any questions, please put them in the comments below. If you do have suggestions, put them also in the comments below, and I will make the videos on those topics like this one was.